Hello, everyone, and welcome back. My name is John, and I'm one of the final year critical care fellows at Dalhousie University. Thank you so much for tuning in today for part 7, the conclusion of my 7-part learning module on oxygen delivery and oxygen consumption for the evaluation of oxygen balance and hypoxemic respiratory failure requiring VV-ECMO. Last time we introduced the concepts of oxygen content, oxygen delivery, and oxygen consumption. And today we'll be concluding with the discussion around oxygen balance and troubleshooting hypoxemia for our VV-ECMO patients. The objectives for this final part of the learning module is to discuss the idea of maximum support for VV-ECMO patients, discuss manipulation of the VV-ECMO circuit in an attempt to improve hypoxemia, discuss possible manipulation of the VV-ECMO patient to improve hypoxemia, discuss the possibility of tolerating abnormal vital signs during VV-ECMO, and to apply the principles of DO2 and VO2 to guide management for VV-ECMO patients, sort of delivered through an example. So just a word on the idea of maximum support. Once a patient has been placed on VV-ECMO for refractory hypoxemic respiratory failure, we can assume that the situation is serious. In all likelihood, the decision was made to cannulate for VV-ECMO because there was an inability to achieve sufficient oxygen delivery, either in general or in a manner that was not injurious to the lungs ongoing. As a reminder, the general accepted idea is that to mechanically ventilate a patient using ventilator settings that are above and beyond the generally accepted lung protective ventilation parameters, as shown here, that this will likely result in ongoing damage to the lungs from the ventilator itself, in addition to the lung injury already sustained from the underlying lung pathology, ultimately decreasing the chance of meaningful lung recovery and survival. Mortality for patients on VV-ECMO remains high, with fairly recent retrospective data from Germany suggesting a mortality rate between 50 and 60% ongoing, and that's despite over 10 years of gained experience managing VV-ECMO patients. Understanding the severity of the situation for those patients on VV-ECMO is important, as it serves to remind us that we may find ourselves in a situation where we are focused to accept abnormal vital signs and values that are outside of the typical parameters for patients in ICU, because at some point we don't have any other option. Put a slightly different way, if the situation is so severe that a patient needs VV-ECMO support, perhaps aiming and striving for SpO2 targets of 100% is not an achievable goal, and we may have to settle for oxygen saturation targets that are less or far less than 100%, as you'll see, sometimes even less than 88%, which is normally representative of the lower bound of what we consider safe for most hospitalized and ICU patients. Understandably, as a patient's SpO2 drifts downward, there is a temptation to return to the mechanical ventilator for added oxygen support, but it's important to remember that in patients on VV-ECMO, the lung damage is likely so severe that all this will accomplish is further damage to the lungs and no meaningful improvement to oxygen saturations or oxygen delivery. We should remember that the general philosophy of VV-ECMO is to allow the lungs to rest and recover, which is accomplished by allowing the VV-ECMO circuit to take over the physiologic role of the lungs by providing a means of delivering oxygen to the blood while clearing carbon dioxide. Before we dive into troubleshooting hypoxemia on VV-ECMO, I'd like to briefly talk about the expected effect of mixing native deoxygenated venous return blood with returning oxygenated ECMO blood. If we think about normal circulation in the body, we see that blood returns to the heart, returns to the right heart, that is, mainly from two large veins, which are the IVC and the SVC. These vessels converge at the right atrium, where returning blood from these two sources mixes and is then pumped into the right ventricle and onward to the pulmonary circulation and beyond. In this situation, essentially all blood returning to the left heart has been through the lungs and thus has had the opportunity to be oxygenated. In the case of patients on VV-ECMO, blood continues to return to the right heart in the same way as in normal circulation, that is from the IVC and the SVC, although now a third contribution of blood return is added, which is in the form of the oxygenated blood exiting from the ECMO return cannula. The point to remember is that not all the blood returning to the patient's heart has been through the VV-ECMO circuit, and thus not all that blood has been or had the opportunity to be oxygenated. Because of this, the blood entering the right heart is a mixture of both deoxygenated and oxygenated blood, and it's this mixture that's pumped forward from the right heart to the left heart through the pulmonary circulation. This is importantly different than normal physiology, as normally deoxygenated blood in the lungs would have the opportunity to become oxygenated by virtue of flowing through the lungs and being exposed to oxygen during their transit before returning to the left heart. But this is not the case in VV-ECMO patients with severe lung pathology necessitating VV-ECMO support in the first place, as that damage to the lung would render the contribution of oxygen from the lungs minimal or negligible. As such, it's expected that during VV-ECMO, especially early on in the disease course, that there will be minimal contribution from the lungs in the form of oxygen diffusion into the system. And thus that mixture of oxygenated and deoxygenated blood that sort of entered the right heart will essentially remain unchanged and exit the pulmonary circulation, returning to the left heart, also unchanged, again existing as that mixture of the two oxygenated and deoxygenated blood. In the end, that mixture will be pumped from the left heart throughout the body, serving as a means to deliver oxygen to the rest of the body, where the lungs are effectively offline related to their severe lung pathology. Because the now arterial blood, again, remains unchanged and exists as that mixture, it's expected that the systemic SpO2 or SO2 will be less than 100%. That's an expectation in VV-ECMO with severe lung pathology, and that's very important. Now, with an understanding of deoxygenated and oxygenated blood mixing out of the way, we can talk about our options for troubleshooting hypoxemia during VV-ECMO. In these situations where SpO2 is low, we have essentially three options in how we can proceed. These options, either alone or in some combination, include 1, manipulation of the VV-ECMO circuit, 2, manipulation of the VV-ECMO patient, or 3, acceptance, perhaps to a limit, of abnormal vital signs. We'll start with our options for manipulating the VV-ECMO circuit. Essentially, there are two main changes that we can make, and these include increasing the FiO2 of the membrane lung or oxygenator, or manipulation of the blood pump. Although increasing the FiO2 of the oxygenator would increase oxygen delivery through the membrane lung oxygenator, the FiO2 of the oxygenator is usually just kept at 100% until attempts at weaning are made. Because of this, manipulating the membrane lung oxygenator FiO2 is unlikely to be an option for troubleshooting hypoxia or hypoxemia, although ensuring the oxygenator FiO2 is at 100% is a reasonable first step when a patient is experiencing hypoxemia. So if increasing the FiO2 of the oxygenator isn't an option, what about manipulation of the pump? By manipulating the blood pump in the VV-ECMO circuit, we can attempt to increase the amount of oxygenated blood returning to the patient. We'll now discuss how this could be beneficial. As mentioned, in normal physiology, blood is returned to the heart from the native venous flow from the SVC and the IVC, both of which are represented in this diagram by the blue arrows. In this example, the combined flow from the IVC and SVC totals 5 liters a minute, and thus the cardiac output will also be 5 liters a minute. During VV-ECMO, as mentioned, a third source of oxygenated blood is added on this venous side from the ECMO return cannula. As mentioned before, this new oxygenated blood mixes with the native blood from the IVC and the SVC, which is then pumped to the left heart and from there throughout the body. In this example, if the native venous return totals 5 liters and the ECMO return contributes an additional 5 liters of oxygenated blood, then the total cardiac output for the patient will be 10 liters. Important to note is the fact that the oxygenated blood is effectively diluted by the deoxygenated native venous return blood. By using this formula, you can see here, we can work out that the blood mixture in this case will be comprised of only 50% total oxygenated blood, which hopefully makes sense. By increasing the blood pump speed, we are hoping to increase the proportion of oxygenated blood we are adding to the mixture. In this example that you see here, if we were able to increase the oxygenated ECMO drainage blood flow to 10 liters a minute, keeping the native venous return 5 liters a minute, we would have an increase in the proportion of oxygenated blood in the mixture, which would increase to 66% from 50 in the previous example. This blood, because it essentially remains unchanged, will also be reflected by a higher proportion of oxygenated blood on the systemic side, as this blood will continue from the right heart to the left heart and onto the circulation. The problem with this idea is that there are limits as to how much blood can be moved through the VV-ECMO circuit. Blood movement through the pump depends on 3 things. 1, the pump speed, measured in RPMs or revolutions per minute. 2, the amount of blood available, that is the preload. And 3, the downstream resistance, which is essentially the afterload. We can start with the effect of the RPMs on flow. By increasing the RPMs of the motor, we're attempting to increase the amount of blood that's being pumped through the pump head over time, thus increasing the blood flow. Unfortunately, there are limitations on how much blood the blood pump can pump. For example, while typical blood pump RPMs range from 2,000 to 6,000 RPM, it's known that blood pump speeds above 4,500 RPM are associated with significant hemolysis, as the structural integrity of the circulating red blood cells is not enough to withstand the forces within and around the blood pump at these speeds. Of course, this limits the utility of the strategy, as shearing and destroying the patient's red blood cells continuously is counterproductive to the overall management of ECMO patients, given the importance of red blood cells for carrying hemoglobin and facilitating oxygen delivery to the tissues in need. Even if the RPMs could be infinitely increased without negative effect of hemolysis, patients would still run into issues as the blood being drained into the drainage cannula outpaces the amount of blood returning to the venous system through the SVC and IVC. The amount of blood available for entry into the VV-ECMO circuit is termed preload. If the amount of blood being drained through the drainage cannula approaches the amount of blood being returned through the native circulation, the total volume of blood in the IVC will fall, and as a result, so will the diameter of the IVC. Below a certain diameter, the walls of the IVC can intermittently sort of collapse and occlude the holes of the drainage cannula, resulting in a visual vibration of the VV-ECMO tubing termed chatter or chugging in some institutions. An extreme version of chatter is something called a suck-down event, which occurs when the walls of the IVC occlude the holes of the drainage cannula, and the suction forces ongoing are such that they can keep the walls of the IVC up against the drainage cannula and hold it there, blocking flow entirely, resulting in the flow of the entire system stopping. This, of course, is dangerous as it can result in systemic hypoxemia and hypoxia. Possible management strategies for chatter include IV fluid boluses and reduction in pump speeds. If a potential contribution to chatter is a lack of venous preload, we can improve the status of preload through the administration of IV fluids, which can potentially increase the IVC diameter and alleviate the obstruction as the IVC expands. This unfortunately has potential negative effects as well, which include further dilution of circulating blood volume, which reduces hemoglobin concentration and thus oxygen carrying capacity, as well as contributes to overall edema. Alternatively, blood pump speeds, RPMs, can be reduced, thereby reducing the suction forces experienced by the IVC walls, also reducing obstruction. The possible downsides of this strategy is that with a reduction in blood pump RPMs comes a reduction in the overall blood flow and a decrease in oxygenated blood return to the patient, which can possibly decrease patient SpO2. Finally, the amount of blood that can be moved by a blood pump is limited by the caliber or size of the return cannulas. In the same way that smaller IV gauges create issues with rapid fluid administration due to Purcell's law, which states that resistance to flow is proportional to the inverse of the radius of the fourth power. Smaller drainage and return cannula sizes limit VV-ECMO flow due to increased afterload. Regardless of the cannula size selected, at some point, at some flow rate, the resistance to flow through the cannula will at least theoretically be limited in terms of flow, and thus the amount of oxygenated blood we can supply to the patient at some flow rate is also limited. This flow limitation is exacerbated with smaller cannulas, which is the take-home point here. And this is particularly problematic when patient body habitus or size results in the placement of smaller cannulas from the beginning. So if we think about this, overall, not a lot of great options for improving hypoxemia in patients involving manipulation of the VV-ECMO circuit. So what about manipulation of the VV-ECMO patient? Well, it turns out that sometimes there are certain management strategies and interventions that we can perform on VV-ECMO patients that can potentially improve oxygenation. In addition to the high likelihood of requiring sedation prior to initiation of ECMO, essentially all VV-ECMO patients will require sedation at some point during their management. Obvious is the need for sedation for the cannulation procedure itself, but the management of sedation for patients beyond this time is complicated, and the ideal strategy has not been determined as of the writing of this module. Given their physiologic instability and need to tolerate the continued placement of large intravascular cannulas supporting their oxygen needs on a second-to-second basis, sedation certainly seems reasonable for these profoundly unwell patients. In addition to protecting the patient from accidental decannulation, that is, literally the cannula accidentally falling out of the patient, sedation and paralytics are beneficial for reducing patient oxygen consumption, VO2, as mentioned previously, and for reducing changes in intrathoracic and intra-abdominal pressures as a consequence of muscular contraction that can lead to chatter or even suck down events through physical external compression of the IVC. Of note, coughing is quite common for patients with ARDS and active lung pathology, as well as for those patients with ongoing mechanical irritation from endotracheal tube placement and need for frequent suctioning. As we often discuss in the unit for our non-ECMO patients, sedation is not without its harms. Although the same data is not currently available to help guide our management for VV-ECMO patients, we know that the use of continuous infusions as opposed to intermittent sedation or no sedation is an independent predictor of longer duration of mechanical ventilation and hospital stay. In addition, we know that for mechanically ventilated patients, deep sedation is associated with longer time to extubation and higher in-hospital and 180-day mortality rates. Analysis of this data also reveals that deeply sedated patients are also at risk for more traumatic recollections of their ICU experiences compared to lightly sedated patients. In addition to these detrimental effects of sedatives, use of continuous sedation and frequent or continuous paralysis makes participation with physiotherapy and conversations about potential for lung transplant for those who will not recover from their lung injury nearly impossible, delaying definitive management. Obviously, these situations are complicated, and as such, individualized discussion about the benefits and harms of sedation and paralysis are needed to ensure the best outcomes for our patients. That being said, it seems unlikely that excessive or unneeded sedation would be beneficial to this patient population. So what about the tolerance of abnormal vital signs? As we've just discussed, there are limitations and drawbacks to the strategies that are commonly used to improve oxygenation in VV-ECMO patients with abnormal SpO2 readings. Because our goal is always to do the best for our patients while doing the least harm, we should take the opportunity to discuss the third option for managing low SpO2, which is the acceptance of abnormal values without any additional intervention. And with this, we've arrived at the second main purpose for this learning module. Perhaps the answer is that we do not need to make any changes at all, and by not reaching to achieve higher SpO2 targets, we can avoid high pump speeds, which we know destroy red blood cells and may cause chatter and suck down events, triggering needless intravenous fluid boluses. while simultaneously avoiding the negative consequences of prolonged deep sedation and paralysis. But how low can we go when it comes to SpO2 targets? Well, the answer to this question, of course, is that SpO2 just doesn't tell us the whole story, and instead, we really need to be looking at the principles that we've just learned and discussed previously in this learning module, namely oxygen delivery, DO2, and oxygen consumption, VO2, and their ratio. Let us again combine many of the principles that we've just learned and analyze an extension to case number 7, which we'll see on the next slide. Again, you can follow along using the workbook titled ECMO Oxygenation in the attached Excel spreadsheet, filling in the necessary. So for case number 7 continued, 4 weeks into a VV-ECMO run with no return of lung function, a patient is well supported and normally has arterial oxygen saturations between 90 and 95% if sedated and paralyzed, with VV-ECMO flows of 7 liters a minute and hemoglobin concentration of 95 grams per liter. When the sedation is weaned, however, the oxygen saturations decline to about 80%, prompting bolus administration of both sedation and paralytics, with resulting improvement in his SpO2 back to the 90 to 95 range. Abbreviated blood gases and summary of known and required values during the period of sedation are shown below. And what we're going to do is use the equations previously provided in the principles of oxygen delivery, oxygen consumption, and the ratio of oxygen delivery to oxygen consumption to determine the DO2 to VO2 ratio and assess if the SpO2 of 80% is actually safe for this patient. So here's the calculation all done, which you can throw into that same spreadsheet that we did before. And by doing that, we can calculate the total cardiac output that comes out as 15.9 liters per minute. We can then use that to figure out the oxygen delivery and oxygen consumption for this patient, which you see here. So we've got an oxygen delivery calculated in the purple cell that comes out to 1,701 mils of oxygen per minute. And compare that to an oxygen consumption of 421 milliliters of oxygen per minute, shown there, calculated in the light blue cell. Finally, we can use these calculated values of DO2 and VO2 to assess the DO2 to VO2 ratio, which is computed in the box titled Interpretation of Results, shown here. We can see from these calculations that even though the oxygen saturation on the systemic arterial blood gas is below what we would generally strive for or even consider safe, that despite that, there is adequate supply of oxygen being supplied to this patient to satisfy their metabolic needs. And that's represented with the DO2 to VO2 ratio well above 2 and, approaching normal, which would be about 5 to 1, and this gentleman coming in at about 4 to 1. Given that there's now some objective evidence that the SpO2 of 80% for this patient is safe under the current conditions, we can feel more comfortable avoiding sedation and paralysis moving forward. This idea that this is adequate for this patient is also reinforced by the fact that the lactate is also normal at 1.2 millimoles per liter, further supporting the idea that this patient is not currently undergoing anaerobic metabolism. And that brings us to the conclusion of this learning module. In this section, we put together many of the concepts that we introduced along the way to understand how to assess overall oxygenation for VV-ECMO patients through the understanding of balance between oxygen delivery and oxygen consumption. We also reviewed the options for managing and improving SaO2 and SpO2 for VV-ECMO patients, including their potential downsides and possible harms. Overall, we learned that by calculating oxygen delivery and oxygen consumption, we can prove to ourselves and the larger team that some of the abnormal values we may see that relate to oxygenation may be perfectly safe for our patients, freeing us up to limit sedation and paralytics in an effort to progress our patients forward. In terms of some conclusions for the overall learning module, these calculations help us prove to ourselves that what may be generally considered abnormal in typical ICU patients may in fact be safe for our VV-ECMO patients. And with this understanding, knowing that we have the ability to repeatedly reassess our patient, perhaps we can feel more comfortable avoiding the administration of paralytics and reducing the overall amount of sedation that we use in favor of waking patients up and progressing their care, knowing that they're safe. Thank you so much for your time in going through these learning module. If you have any questions, comments, feedback, concerns, please feel free to reach out to myself or Dr. Witter at any time. Thank you so much. Have a great day.